So it's 12 o'clock. Let's get started. Welcome, everyone, and thank you for tuning in. I'm Aline Serfati. I'm a musculoskeletal radiologist at Médica Lagos, which is located in Cabo Frio in the state of Rio de Janeiro, Brazil. And I'm also one of the coordinators of the Musculoskeletal Image Group of Rio de Janeiro, together with Silvana Mendonça and Pedro Dias, who I take the opportunity to thank now. This is going to be the second session of the MSK case presentation series, and it's focused on rheumatology. We are happy to present 4 outstanding speakers today. But before I introduce our first speaker, I'd like to thank Philip Tierman, Hilary Humans, and Beran Gamini, who believed in this project and helped me make it happen in partnership with our group from Rio de Janeiro. A couple of housekeeping points before we begin. If you have questions, please put it in the chat box, and at the end, the speakers will respond to them. This video will be recorded and uploaded on the YouTube channel of the OCAD, which is OCAD-MSK, and also on the YouTube channel of the Radiology Society of Rio de Janeiro. This information will be available online and on social media, and will be sent out on OCAD as well as the link to the YouTube channel. A quick reminder before we begin: attendees have not been given the permission to screen record any of these presentations, as it may contain material that is under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you so much for tuning in, and with that, I will introduce our first speaker. We have the pleasure to have here today Dr. Clarissa Canella. She's an adjunct professor of MSK Radiology at Universidade Federal Fluminense and a practicing radiologist of DASA Group, currently working at Clínica de Diagnóstico por Imagem and Alta Excelência Diagnóstica. She's very involved in MSK research, having authored and co-authored original research and book chapters. She's also very active in MSK education, and she has presented in several Brazilian and international conferences. She's a member of several radiology societies in Brazil and a member of the International Skeletal Society, being nominated as the next chairman of its outreach program. With that, Clarissa, please share your screen.
Hello, everybody. So let's start. Just let me see here. So good morning, good afternoon. First, I would like to thank Aline Serfati and the organized committee for invitation. So our case is about a man of 46 years old with this palpable periangular lesion of the second right finger for 12 months. Note that he presented this longitudinal striations of the nail plate. This condition was unresponsive to antibiotics and also other medications. Mycological examination of the nail was negative, and there's no laboratorial findings. The patient performed articular and nail ultrasonography on September. So I'd like first to review some aspects of the anatomy of the nail. So here we have the distal and intermediate phalanx, here the dorsal plate, volar plate, nail bed, nail matrix, and the anthesis of the extensor tendon. We can see here that this patient did not have any findings of the plates of the nail bed and also the nail matrix. But when you look for the extensor anthesis, we can see this extensor tendon that is thickening and with the high vascularization on power-Doppler ultrasound. We can also see some bone erosions here and some periosteal reactions of the distal phalanx. On radiography, we can see this periosteal reaction here on the distal phalanx, also with some perarticular erosions and this thickening of the perarticular soft tissue. This patient had already performed 2 MRIs, and we could review these images. First one was in April, and we can see here that we have this distal phalanx osteitis, also with subtissue edema surrounding the extensor and flexor tendon. The second one was in July, and we could see basically the same findings. So here the distal phalanx osteitis, and also the soft tissue edema surrounding the tendons. So regarding this imaging findings, we can see distal phalanx osteitis with erosion, periosteal reaction, anthesitis of the extensor and flexor tendons, and the periarticular soft tissue edema and thickening. These findings are really typical and characteristic of a subtype of psoriatic arthritis. And when we look for the nail of the patient, we can see also these longitudinal striations with some pitting that are really characteristic of psoriasis. So the diagnosis of this patient was psoriatic onypachydermal periostitis, the POP lesion. Imaging findings for POP lesions are really characteristic, and that's why I would like to show 4 cases that we saw in the last year in our service. So here we have a female, 42 years old, with this ungual dystrophy, and here we can see the distal and proximal phalanx osteitis, also bone erosions with periosteal reaction, anthesitis of the extensor tendon with high vascularization on power Doppler, and also the periarticular soft tissue edema, features that are really similar to our case. Second case, we are going to see basically the same, female, 38 years old. So here, distal and proximal osteitis of the hallux. Here, the soft tissue edema surrounding the extensor tendon, and the periarticular tissue edema and thickening. Third case, the same, distal osteitis of this phalanx with the thickening of the nail bed, and also soft tissue edema of the surrounding extensor tendon, periarticular soft tissue edema and thickening. And the last one, the fourth case, male, 40 years old, and we can see exactly the same imaging findings. Distal phalanx osteitis of the hallux, here erosion, bone formation on radiography, anthesitis of the extensor tendon with power Doppler positive, and also periarticular soft tissue edema. On that case, we also performed dynamic perfusion imaging just to illustrate, and here we can see that we have this high vascularization tissue with early enhancement of gadolinium exactly located on the extensor and tendon and flexor tendon anthesis, and here the time intensity curve. So POP lesion is a subtype of psoriatic arthritis that is characterized for psoriatic onychopathy, painful soft tissue thickening, and some radiological evidence of lesion, usually erosion and periosteal reaction of the distal phalanx. The patient can present or not cutaneous psoriasis, and in some cases, we can also have the distal interphalangeal joint involvement. Physiopathology is related to extensor tendon attachment here. So this structure sends some fibers that directly connect to the nail bed, allowing the spread of inflammation from the subungual region to the bone. When you look for POP lesion on PubMed, we can see a few results. I found 30 articles, 21 related to imaging. I'd like to show you only 4 or 5 that are the most important. So that first one, it's an important article because this article defines the POP lesion. As we can see here, we need psoriatic nail lesions for that, with soft tissue thickening of the distal phalanx and some radiological involvement of the bone that usually, as I said, is periosteal reaction and bone erosions. The second one is also an important article because this article explains better the physiopathology of POP lesion. This one is an article where the authors defend that change are absent in the distal interphalangeal joint in regarding a pop lesion, and this is really controversial in literature actually. Just to remember that sometimes psoriatic skin lesions are absent when we do a diagnostic of pop lesion. For this article of 2016, this is really interesting because it's a review of literature, and we can see that only 4 years ago, we had only 22 cases of POP reported in literature. And that last one, it's the most recent, and it's an article showing a patient perspective of the disease. So look at this nail. This patient presented a lot of pain with deformity. She had visited a lot of doctors and no one was able to solve her problem. And this article is just to illustrate how this diagnostic is clinically difficult, demonstrate the importance of the imaging. So key points for this case: we need to know pop lesion, we need to know pop imaging findings that are really characteristic as osteitis, erosion, periostal reaction of the distal phalanx, enthesitis of the extensor and flexor tendon, and periarticular soft tissue edema to allow the accurate and early diagnosis and initiate the curative therapy for these patients. I'd like to thank my colleagues that helped me in this presentation, and thanks for your attention.
Thank you, Clarissa. Beautiful case. Thank you. Hillary? Please open your microphone to present Stephanie.
Hi, good morning. Can you hear me?
Yeah.
Mm-hmm. Okay.
Perfect.
Good morning. I'm Hillary Humans. It's my pleasure to introduce Dr. Stephanie Bernard, who's a musculoskeletal radiologist on faculty at the San Antonio Uniformed Services Health Education Consortium since October 2018. Stephanie received her MD from the University of Texas at Houston in 1994. She completed radiology residency at the Bethesda Naval Medical Center in 2002 and served as teaching faculty at Portsmouth Naval Medical Center until 2007 and residency program director up until 2007. She completed her musculoskeletal fellowship at the Mayo Clinic in Jacksonville, Florida from 2007 to 2018 and was on faculty at Penn State Hershey Medical Center in Pennsylvania from 2008 to 2018, where she served as musculoskeletal radiology fellowship director and was promoted to full professor of orthopedics and radiology. She's been a member of the Society of Skeletal Radiology since 2008 and a member of the International Skeletal Society since 2017. She was actually a co-editor of Ann Brower's Arthritis in Black and White. Welcome, Stephanie.
Thank you. And let's see if I can get this up. Share screen. Okay, hopefully me, thumbs up, and seeing my screen. Okay. Thank you, Dr. Humans and the OCAD community for the invitation to participate in this rheumatologic discussion. I have no disclosures. So let's jump into this case. This is a Ferguson view of the pelvis in a 17-year-old male with hip and back pain. To keep this from being an eye test, I'll zoom in on the SI joints. What would your diagnosis for these SI joints be? When I'm in doubt, sorry.
So the right answer would be bilateral sacroiliitis, but I recognize that sacroiliac joints can be really hard to look at.
I would say the correct answer is bilateral sacroiliitis, but when I'm in doubt, I like to pull open some normals to compare with. Here on the right of the screen, I'm including a 37-year-old female with what I would call a normal appearing SI joint, where the joint shows a smooth undulation and sharply defined subchondral bone line that could be drawn with a sharpened number 2 pencil. That's in contrast to the widened irregular contour of the lower sacroiliac joints in our patient due to erosions, and where there is subchondral sclerosis obliterating visualization of that subchondral bone line along the iliac side of the joint. The sacroiliitis can also look similar to osteitis condensans ilii, where there is a triangular region of sclerosis along the inferior iliac side of the sacroiliac joints, and occasionally some along the sacral side of the joint, but with maintenance of that normal, smooth, undulating contour and normal width, in contrast to our patient. This patient had a concurrent MRI of the pelvis, which shows both classic structural lesions of prior inflammation in the form of erosions and subchondral sclerosis, but also shows active inflammatory lesions as evidenced by the bone marrow edema. Looking at the rest of the pelvis, you see extensive marrow edema in the posterior iliac wings, at the anterior superior iliac spines, and even areas of involvement in the right femoral head with a small right hip joint effusion. I'll magnify the right anterior superior iliac spine and notice that there's cyst-like change along the metaphyseal side of the physis for the apophysis. Would you still feel good with a diagnosis of bilateral sacroiliitis likely representing spondyloarthritis, or would you give a differential, make any other recommendations? Clearly, by the way I'm asking this, you know it's a setup. Well, this is where I sought some clinical context. The patient's HLA-B27 negative, but that doesn't preclude the diagnosis of a spondyloarthritis. There are mildly elevated inflammatory markers, not surprisingly, given the amount of inflammation seen on the imaging. And the patient, though, has had a waxing and waning set of symptoms for years, so potentially JIA or juvenile spondyloarthritis, but with only marginal response to NSAIDs. In digging through the packs, there's a knee MRI from 3 years prior. Would this change your diagnosis? Notice that the disease is confined to the metaphyseal bone marrow without any joint abnormality, and much more in the distal femur than the proximal tibia. Knowing what this patient's pelvic MRI looks like, now chronic non-bacterial osteomyelitis, what we used to refer to as CRMO or chronic recurrent multifocal osteomyelitis, is the best diagnosis. JIA would typically be joint-based, and the spondyloarthritis or even a juvenile spondyloarthropathy would be more enthesial and joint-based. Now, the other item I left you in the differential was a metabolic bone disease. And metabolic bone diseases in kids, and specifically scurvy, which this is what you're seeing in this patient, can present with marrow edema or infiltration that I think looks very much like CRMO or CNO, often with some soft tissue involvement. This is another child with scurvy, and it shows some of the other ways that you can differentiate it from CNO. Since metabolic bone diseases are systemic, it tends to involve all of the metaphyses, and we'll show the most involvement at the metaphyses that are most biologically active. That's classically the distal femur, proximal tibia, and proximal humerus, where most of the bone growth is occurring. So if you have a wide field of view, you may see it systemically, which will help you differentiate it. The other feature that can help you is that often these will be associated with subperiosteal hemorrhages, as is seen in the proximal humerus, or may show you the soft tissue involvement as we're seeing in the lower extremities. And this is just one more example of scurvy from a radiographics article in the literature. So, in going back to our original patient's diagnosis, what is chronic non-bacterial osteomyelitis? It's an autoinflammatory disease of bone for which no reliable cause or specific genetic HLA association has yet been identified. While inconsistently addressed in the literature, it is often discussed in association with another entity, Sappho syndrome, as potentially the spectrum of the same disease. Now, Sappho is an acronym for the signs of the disease: synovitis in the joints, acne, pustules on the palms of the hands and soles of the feet, hyperostosis, and osteitis. Both entities can present with either solitary or multifocal bone marrow edema lesions and inflammatory symptoms, and both are a diagnosis of exclusion after ruling out infection or other specific rheumatologic condition. Chronic non-bacterial osteomyelitis is classically described as being more peripheral involvement in children and adolescents, while Sappho syndrome, anterior chest wall pain, and involvement in young adults or middle-aged adults. But there's a lot of overlap between the entities. I've encountered chronic non-bacterial osteomyelitis many times in the sacroiliac joints and spine, where it may mimic infection or spondyloarthritis. This is another patient where there's asymmetric bilateral sacroiliac joint disease. This one was associated with non-marginal inflammatory spondylodiscitis changes at the end plates and irregularity on the plane films that received a workup and eventually a diagnosis of exclusion of CNO. In the periphery, CNO tends to present with inflammation at the metaphyses, where it produces lucencies over time that may be surrounded by fading sclerosis, here seen in the distal tibia. And in this example from the literature, these lucencies may take on a classic pyramidal configuration where their base is at the physis. The most common symptom with Sappho syndrome is anterior chest wall pain, and the classic lesion demonstrated is involvement of the medial clavicle with hyperostosis, osteitis, and resultant enlargement, as is seen in this patient. It may be associated with costosternal hyperostosis, erosive changes at the sternoclavicular joints, or sternomanubrial involvement. As mentioned, it may also present with spine inflammatory changes that may mimic a spondyloarthropathy, or less common, but a classic finding of inflammatory hyperostosis of the mandible. Interestingly, some of the patients with CNO and Sappho present more with cortical hyperostosis than the marrolytic lesions and sclerosis. This woman's a nice example of this cortical involvement seen along the medial distal femur. And another feature of CNO and Sappho that helps differentiate it from the spondyloarthropathies is that these patients tend to respond better to bisphosphonates than the NSAIDs and the anti-TNF alpha medications that are used for spondyloarthropathies. But these patients can be quite refractory to treatment. This patient nicely demonstrated the progression of the hyperostosis of the femur over a 5-year period despite treatment. The ACL was from a soccer injury. So some takeaway points. Our understanding of chronic non-bacterial osteomyelitis, the name that has been given to replace CRMO, as well as Sappho syndrome, is still evolving. We don't understand the underlying mechanism of disease, and in some texts you'll see them spoken of as a spectrum of the same disease, whereas other places you'll see them split into separate entities, and eventually maybe they will be further defined. Both chronic non-bacterial osteomyelitis and Sappho syndrome can mimic a spondyloarthropathy, or if it's presenting unilaterally in an SI joint, it may mimic infection. When you're encountering what looks like sacroiliitis, think about CNO and Sappho syndrome and ask about the timeline of symptoms as well as other joints of involvement. Thank you, and here are a few additional references.
Thank you, Stephanie. Hi, Robert. Okay, you're muted.
Hi.
Hi.
Sorry I'm late.
Okay, so I'm introducing our next speaker, who is Taciani Cantarelli. She's a practicing musculoskeletal radiologist at HCOR and Teleimagem in São Paulo, Brazil, where she trained during her clinical musculoskeletal fellowship. She's also a former research fellow at NYU and a member of several radiology societies in Brazil. She has authored and co-authored articles on the musculoskeletal field and is a very active MSK educator, lecturing in several Brazilian radiology meetings. Taciani, please share your screen.
Thank you. Just a minute.
Hi, good morning, everybody. I'm Taciani Cantarelli. I'm a musculoskeletal radiologist from São Paulo, Brazil. I'd like to thank you all the organizers, especially my colleague Eline, for inviting me to speak here today. So here's the case. It's about a 53-year-old man with polyarthritis for at least 5 months, including small and large joints, symmetric, with significant limitations in daily activities. The patient has a personal history of melanoma with surgeries on the left leg 12 years ago, and also another 2 procedures on the left groin due lymph node metastasis 4 and 3 years ago. He also had previous chemotherapy, and during the physical examination, patient had pain and swelling, especially in ankles and wrists, without motor or sensory deficits. The laboratory finds were unremarkable, with negative rheumatoid factor and anti-CCP. These are the initial radiographs of both hands on AP view. There is periarticular osteopenia in relation to joints of the hand, including metacarpophalangeal and interphalangeal joints, as well as the wrist. The joint spaces are narrowed in the proximal interphalangeal joints, but the distal interphalangeal joints are spared. There are also small subarticular erosions of the proximal interphalangeal joints pointed by the arrows. Now, looking at the X-rays of the wrist in the AP view, again, we can see periarticular osteopenia, especially on the 4th and 5th metacarpal base. There are small erosions on the right lunate and the left scaphoid pointed by the arrows, but the joint spaces are preserved. Now we have radiographs of sacroiliac joints that demonstrate mild degenerative change on both sides of the sacroiliac joints without clear erosions or ankylosis. There, we can see also the surgical clips projected on the left hip, and there are also some degenerative change on the L5-S1 spine level. Now we have X-rays for both knees, where we can see again periarticular osteopenia, mild loss of joint space in both femorotibial compartments, with lack of subchondral sclerosis and osteophytes. Soft tissue density within the suprapatellar recess on lateral radiographs related to joint effusion. Surgical clips from his previous surgeries are also noted in popliteal fossa, and there are small degenerative antizophytes of the superior pole of the patella on both knees. The patient's last X-rays are of the feet. Once again, we have periarticular osteopenia, more diffuse in the feet than in the other joints, predominantly involving the interphalangeal and metatarsophalangeal joints. There are small subarticular erosions of the proximal interphalangeal and metatarsophalangeal joints. The articular spaces are narrowed in the proximal interphalangeal joints, and the rest of them are well preserved. On the same day, the patient underwent an MRI of the right wrist. On the left, we have the T2 weight image in the coronal planes, showing diffuse joint effusions in all compartments with synovial inflammation. We can see the same erosions of the right lunate that we previously saw on the X-rays. There is just articular bone marrow edema and also diffuse tenosynovitis and soft tissue swelling. Here we have the axial planes from the same right wrist MRI. where you can note the same image features like just articular bone marrow edema, joint effusions with synovial inflammation, and soft tissue swelling. It's better noted that diffuse tenosynovitis involve all the extensor and flexor tendons. Moving on to the last image study, we have a right ankle MRI, also from the same day, that shows on T2 weight image just articular bone marrow edema. There are also posterior tibialis tenosynovitis and peroneal tenosynovitis. Once again, diffuse joint effusions in all compartments with synovial inflammation. We can see erosions on the distal tibia, and there is also soft tissue swelling. So the summary of this case, it's a 53-year-old man with polyarthritis with synovial inflammation and erosions and negative laboratory finds. He has a personal history of metastatic melanoma, and looking at the image features, what type of arthropathy do they are in favor? So it's clear there is an inflammatory arthropathy, but what type? So polyarticular disease does not support infection. Radiograph features are not consistent with seronegative. There is no axial involvement, no enthesitis, and also is not consistent with crystal-induced arthropathy as gout. So osteopenia, erosions, diffuse synovial inflammation, narrow joint spaces, especially in the proximal interphalangeal joints sparing the distal joints, were consistent with rheumatoid arthritis. So despite the laboratory finds were negative, the patient was diagnosed with rheumatoid arthritis based on ACR-LR criteria and also were consistent with imaging features. But there is one thing that we should always check in the clinical history of a patient, and if the patient is using any drug. In this case, the patient was using Nivolumab, an immune checkpoint inhibitor drug, for 18 months to treat the metastatic melanoma. So we need to consider drug-induced arthritis in our differential diagnosis, including immunotherapy. So this turned to be seronegative rheumatoid arthritis, immune checkpoint inhibitor induced in a patient with metastatic melanoma treated with Nivolumab. This type of drug is relatively new. This immune checkpoint inhibitor was approved by the FDA in 2014 for advanced melanoma. In Brazil, this drug was approved only in 2016 by Anvisa, which is the Brazilian Health Regulatory Agency. In 2017, the FDA expanded the approved use to patients with resected melanoma with lymph node involvement or metastatic melanoma as our patient. So Nivolumab is a human DG4 monoclonal antibody with high affinity for the programmed DEF1 receptor. Is the first PD-1 immune checkpoint inhibitor approved by the FDA. Immunotherapy restores T-cell anti-tumor response by modifying host response, thus inhibiting the cancer immune escape pathway and allowing the immune system to recognize and fight cancer cells. So this drug is the first-line treatment of metastatic melanoma and also can be used as the second-line treatment for other malignancies such as renal carcinoma and squamous cell lung cancer. Since the drug is new, the Nivolumab-induced arthritis is also a new pathology. There's a few studies about that. I found some case reports, but about the mechanism is known that defects in PD-1 receptor and PD-1 the ligand pathway contribute to synovial inflammation in rheumatoid arthritis patients. The study suggests that the patients with rheumatoid arthritis have a soluble form of PD-1 within the synovial fluid that binds competitively to the ligand, the PD-L1. It's unclear if the duration of exposure to such medications contributes to the severity of arthritis. We still need further studies to confirm that. So now there is a companion case. We have a wrist MRI of two different patients on T2 weight image in coronal and axial planes. And when you put the case together side by side, we can compare better and note a lot of similarities. We have the same features of joint effusion, synovial inflammation, tenosynovitis, and just testicular bone marrow edema and erosions. On the left, we have a classic rheumatoid arthritis seropositive, and on the right, we have our case of drug-induced rheumatoid arthritis. So finally, we have a comparison between the initial wrist MRI and after 7 months of treatment with the suspension of the Nivolumab. The use of steroids and discontinuation of the Cupid drug are the mainstay treatment of immune-related side effects of PD-1 inhibitors. In patients with rheumatoid arthritis and previously treated or untreated skin cancer, like melanoma and non-melanoma, the American College of Rheumatology recommends the use of disease-modifying anti-rheumatic drugs. The patient was treated using a combination of steroids and methotrexate, and his symptoms has improved remarkably and stay under control. He still continues to follow up using only methotrexate to suspend the steroids, but comparing the image, we can see how synovial inflammation improved and stopped the progression of the disease. So just finish my presentation with the take-home message. We know that there is a large and heterogeneous group of drugs that can cause drug-induced arthritis. And recognizing that joint symptoms may in fact be drug-related not only saves time and unnecessary investigations, but also can prevent needless suffering and morbidity due to late recognition of a drug-induced arthritic condition. The case demonstrates that patients can be at risk of acquiring seronegative rheumatoid arthritis as a deleterious side effect. We need to be aware of the rheumatological manifestations that can be seen in an adverse effect of drugs. Early recognitions of symptoms and diagnosis key to a more successful patient outcomes. So thank you everyone. Thanks for the audience.
Thank you, Taciani. Thank you very much.
Okay. Hello. Can I start speaking? Yes.
Yeah, please.
Okay. Hillary Humans again. I'm very happy to see Dr. Robert Lambert has joined us. He's our next speaker. He graduated from Queen's University, Belfast, Northern Ireland, United Kingdom in 1980. He trained in his residency in Belfast and then completed postgraduate training with musculoskeletal radiology fellowship in Toronto, Ontario, Canada. He holds fellowships both from the Royal College of Radiologists, that's in the UK, and the Royal College of Physicians in Canada. He was head of MSK radiology at the University of Alberta from 1989 to 2002 and was at the forefront of MSK radiology innovation, introducing many MSK MRI and interventional MSK services to Canada. Dr. Lambert was chair of the department until 2016. His primary research interests are MSK MRI and the imaging of arthritis. This includes the development and clinical validation of image-based definitions and scoring tools for assessment of spondyloarthritis and osteoarthritis, MRI evaluation of hyaline cartilage and bone marrow, and randomized trials of arthritis therapy. His research activities involve networks of Canadian and international investigators, and he's worked with multiple collaborative groups that have participated in the development of scoring systems based on imaging that are used in both diagnostic and therapeutic settings, as well as clinical trial research. He's published over 140 peer-reviewed articles and book chapters, and is a member of several international societies related to the MSK radiology and arthritis research. Take it away, Rob.
Thank you very much. I'm just making sure that you can all hear me okay.
Yes, okay, perfect.
Thank you very much. I'm going to finish off here with a very simple case for which there is no diagnostic or treatment dilemma at all, but it's an interesting case because of a series of images that we have. So I'm just going to talk for a few minutes about sacroiliitis and focusing on one case in particular. So this case is a 21-year-old man who was active in sports and had occasional back pain. He played ice hockey, and that's not unusual for ice hockey players to have pain occasionally. And when he gets this pain, it responds well to NSAIDs. At the time he presents to the rheumatologist, he's asymptomatic, and he presents because his father has ankylosing spondylitis, and he's concerned about that. He's no convincing features of inflammatory back pain. When he gets the pain, it only lasts a few weeks. He has no morning stiffness. The pain is not worse at night. His BASDAI is almost normal. Although one possible flag is that it does improve with NSAIDs, but a lot of back pain can do that. His X-ray is normal. So the patient asked the rheumatologist 2 questions. Could I have ankylosing spondylitis? And can I have an MRI scan? Because I'm worried about that, because I don't want to have my father's disease. And so the answers are yes, he could have ankylosing spondylitis, but no, he can't have a clinically indicated MRI scan because he's asymptomatic. When he gets his pain, it responds to NSAIDs, and the MRI would not change management and may not change the diagnosis. So in Canada, an MRI scan would not be clinically indicated. However, he was offered the opportunity to volunteer for a research MRI scan. We have a prospective cohort of subjects that we enrolled, looking at them, the forecast cohort. And so he volunteered for that prospective cohort trial. And here's his first MRI scan. And here we see, this is when he's 21 years old and asymptomatic. I look often, first of all, at the stir, and we see here a patch of bone marrow edema in the left sacral ala. And then surrounding that, on the iliac side, there's a little bit of stenosis, and there is definitely some erosion. The lowest part of the joint is relatively normal, although there does seem to be some inflammation in the joint space at this time when we compare to the other side. There's the edema and the erosion, as we see. Now, the question is, does the patient have ankylosing spondylitis? Well, the answer is no. His X-ray is normal. His labs were normal. He's never had pain for more than 3 months, and he does not meet any of the classification criteria. So he doesn't, at this stage, have ankylosing spondylitis. But he does have sacroiliitis. Now, he probably has non-radiographic axial spondyloarthritis. This is a terminology that an international research group has developed for those patients who have not yet developed radiographic disease and don't meet the criteria. And this is probably the situation he's in. But technically, he actually doesn't meet NR-AXS-PA classification either, because he's asymptomatic, and this is the only finding. Now, in the past, and even today, some of these cases may never progress to ankylosing spondylitis. In some cases, what we see here may resolve spontaneously and never recur. And without an MRI scan, you would never know that the patient had ever had anything wrong with them. So he's followed up 2 years later. He remains asymptomatic. He's had no treatment at all. In the meantime, he's not been taking any NSAIDs because he has no pain. And here is an MRI scan 2 years later. At this time, we see that there is fat metaplasia on the T1 weighted image that has developed in the location where he previously had bone marrow edema. Yes, the articular surface looks slightly irregular, and I do think there is some residual erosion clearly present here on the sacral side of the joint. This does not look normal, but the erosion can heal. And here we see some bright fatty signal in the location close to or in the joint space. And this is probably a phenomenon of bone forming where some subtle erosion was previously present. So he has the fat metaplasia and the backfill and some residual erosion that are typical for spondyloarthritis. But he's asymptomatic at this time and would not clinically have an indication for imaging. Now we see him at 4 years. He has an MRI scan annually, and he comes back now 4 years later. At this time, he has recurrent low back pain, but it remains well controlled with NSAID. He has switched to naproxen at this time, but remains otherwise asymptomatic. Now we see that there's some recurrent bone marrow edema low down on both sides of the left joint. There's some increased signal in the joint space in comparison to the other side, so there's inflammatory joint signal. And the backfill that we saw in the lower part of the joint has disappeared. So a lot of these changes are not permanent. So he has new erosion, new inflammation, and inflammation in an erosion cavity. There's the fat lesion, the inflammation, and the erosion the inflammation in the erosion cavity. These are all typical signs of a spondyloarthropathy. At this time, his X-ray is abnormal. So he has a follow-up X-ray at this time, and we can see here that he has definite erosion in the left ilium. And we also see in the MRI that at this point, he has developed some inflammatory enthesopathy. He comes back now after 5 years. So this is 5 years later. He's asymptomatic at the moment of this scan, although his intermittent back pain is becoming more frequent, but it is generally well controlled with naproxen. He doesn't take it all the time, but he takes it most of the time. Now we see there are multiple foci of inflammation in the in the right SI joint, with inflammation in the joint space. We see erosion here in the subchondral bone. Some of the fat metaplasia on the left joint is not as homogeneous as it previously was. There's some residual edema low down on the left side. But also notice in the meantime that he has developed fat metaplasia in the lower half of the right joint. This is almost certainly an indication that in the interim period of 1 year that he'd had some inflammation in this area which subsequently subsided, and then it's deteriorated in this area. I want to point out the backfill has recurred here on the left side, even during a period where there was no significant inflammation in this joint, which is a very interesting observation. At 6-year follow-up, he had become much more profoundly symptomatic. He now had pain in his back, his neck, his heels, groin, shoulders, stiffness for 3 hours, and weight loss. His ESR and CRP were markedly elevated. And so at this time, he went on to take biological therapy and responds very well to that biological therapy. And of course, at this point in time, he has ankylosing spondylitis and meets all the criteria for that. So several points I want to make here is that symptoms are often mild and non-specific in early disease and highly variable, as are the MRI findings, and they don't closely correlate. The progression is typically slow, and treatment decisions are not primarily based on imaging findings. You must treat the patient and not the scan. The key MRI findings in early disease are bone marrow edema in subchondral bone, but this is highly variable and it's usually asymmetrical. We see joint space inflammation, and we may also see capsulitis and enthesitis. The structural damage changes that we may observe are erosion, which is more specific for spondyloarthritis, sclerosis, which is less specific, fatty lesions in the bone marrow, and they should follow the pattern of the bone marrow edema lesions, being subchondral in location. The fatty lesion in the healing erosion, which we sometimes call backfill, and of course later on bone formation with budding and ankylosis. Now, there's a few myths here that I want to emphasize, and this case shows beautifully that sacroiliitis is not a synovitis. It's a disease of bone. Rheumatoid arthritis primarily affects the soft tissues and bone secondarily. We saw a beautiful case of that earlier. But ankylosing spondylitis and the spondyloarthropathies that involve the axial skeleton, it is primarily an osteitis involving the cartilage interface of the subchondral bone, and the soft tissues are only secondarily affected. The second thing is the active inflammation is not acute. All the lesions we see are relatively chronic, lasting for months or years. And so we refer to the inflammatory lesions as active rather than acute, because the active lesions and the structural damage lesions tend to be all chronic with an average delay in diagnosis of 9 years. And the final thing is that the disease is rarely symmetrical in the early stage of disease. The symmetry is only true in the late stage of disease whenever multiple structural damage changes become permanent. So yes, on X-ray, the changes in ankylosing spondylitis may be symmetrical, but that is rarely true on MRI, and especially not in early disease. And here we see another ankylosing spondylitis patient in early disease with florid unilateral disease. So expect it to be asymmetrical and unilaterally. And finally, the structural damage changes are not all permanent, especially the ones that we see in early disease. It's remarkable how the fatty lesions, erosion, and sclerosis can all disappear, and the joint, if the changes are early, can revert to a relatively normal appearance. Obviously, as it becomes severe and erosion is extensive, then the changes are permanent. Thank you very much.
Thank you very much. It was a great case. So there's a question from the audience. Dr. Zavares, she's asking how to report all the alterations. I think it's regarding Clarissa's presentation. So how to report all the alterations? Do you divide by finger, make a table dividing B mode and Doppler findings? Any particular classification for psoriasis?
If I divide by finger, no. If we have the same imaging findings in all fingers, I report everything together. If I make a table dividing, no, it's not exactly a table, but I give a B mode and a power Doppler grade for each joint that present lesion. And any particular classification, no, I use the Euler and Numeract classification for synovitis.
Thank you, Clarissa. There's a question for Dr. Lambert. I have encountered similar from BK. There's just the letters, there's no name here. I have encountered similar case followed up for 3 years. Should we create a term smoldering ankylosing spondylitis similar to smoldering myeloma? What do you think?
Good question.
It's a very good question, and I don't think we know how to handle that situation. I do believe that there are some patients who develop a mild sacroiliitis. It resolves spontaneously, as we saw earlier in this case, and then it perhaps comes back on that or the other side, resolves spontaneously again, and the patient has recurrent pain. The challenge is that without the progression of the disease to more extensive destruction or on to ankylosis, it's challenging to classify those cases. So we probably should have such a category. Do those patients need biological therapy is really one of the key questions. And if the symptoms are tending to resolve spontaneously, then we would not know that answer. So we can have that classification of smoldering disease, but how would we treat it is another complicated question.
Thank you. I don't see any more questions here. So this session was recorded, and I said it before, but I'm saying it again for the ones who weren't here in the beginning. So this session was recorded and will be available, will be uploaded on the YouTube channel of the OCAD, which is OCAD-MSK, and also on the YouTube channel of the Radiology Society of Rio de Janeiro. Thank you all for tuning in, and we are looking forward to the next session, which will be held on January 29th, with focus on sports imaging. Thank you very much.
Thank you very much.
Bye, thank you.
Bye-bye. Thank you.